Good evening, everybody, and welcome to this another web-based session. This is essentially, as we said, this is from Apollo Gleneagles Hospitals, Kolkata, and courtesy this current scenario, we have taken recourse to this web-based teaching, and because our students said that there are other people who are also interested in joining and kind of interacting with us and helping us also learn, we thought that we will use another portal, and this is the portal of HCP, which is Healthcare Professionals. And this is the first time that I am trying to do this on their portal. And let's see how we go about it. Today or this evening, we have Dr. Anisha De. She is one of those passionate pediatric anesthesia person. She loves putting children to sleep with an assurance that they will be up and about after the procedure is over. I'm very thankful to her to be here this evening.
Yes, sir. Thank you very much, sir. So good evening, doctors. Good evening, everyone present here. HCP Forum welcomes you all for the first webinar of the anesthesia web series we have planned with Dr. Sengupta and his team. So just to give you an introduction about HCP Forum, this is a new forum which has been developed. It is a unique online platform for all healthcare professionals. It is meant to connect, it is meant to network, academically strengthen yourselves in your respective fields of specialization. So one of our core interest areas is this web-based lecture series. And as you know, this is a pandemic situation where we are forced to direct ourselves to this online format. So I'm honored to have this mastermind, Dr. Sengupta, behind this webinar series, who actually needs no formal introduction. Sir has this academic inclination, and I know him as an eloquent orator. So he is the chairman of Kolkata Anesthesia Academy, along with his professional achievements. I don't want to go into those things. So this is an academic endeavor taken up by Kolkata Anesthesia Academy along with HCP Forum. And this journey will continue in collaboration with Kolkata Anesthesia Academy under the able guidance of Dr. Sengupta. So we are pleased to have Dr. De with us along with Dr. Sengupta. Over to you, Dr. Sengupta. I think Dr. Anisha is also
here. Thank you. And before we start, I think I need to flaunt what I am wearing. This is essentially because if people have been following my greatest passion, which is not anesthesia, not anything else other than football, and the club that is the dearest to me for a long, long time. So we have won the cup league after 30 years, and which is why you will find the same jersey, I think, which Ian Rush wore 30 years back. I'm with it tonight. So all the best, and go ahead, Anisha, with the basic principles of neonatal anesthesia.
Yeah, thank you. Good evening, everybody. Learning, as we all know, is a dynamic and a two-way process. Although the virus has taken a huge toll on us, it can never stop us from learning, unlearning, and sharing our knowledge. I would like to thank the organizers for creating such a wonderful platform for us. My sincere thanks to Dr. Saikat Sengupta for giving me this opportunity. Neonates, as we all know, are neither small adults nor small child, right? So they are very tiny creatures, vulnerable, have very dynamic physiology, at a very high risk of developing all anesthesia-related adverse effects, and they belong to a very high group of mortality rates. But we cannot forget that they are fighters. Although they desaturate very fast, become apneic very quickly, develop sudden cardiac arrest, they are also easy to revive. So the key of success is constant vigilance, rapid recognition of any events, swift interventions. Yes, a full-term healthy, normal birth weight baby with no comorbidities exist, but unfortunately, they don't usually come to us. Hence, our neonates may be low birth weight, premature with associated cardiac and congenital anomalies, and disturbed immature physiologies and anatomies. So our approach has to be a little different from the grown-up children. This topic is itself vast, very difficult to summarize in such a short time, but I shall definitely try my best. We will not be discussing in details the anatomy and physiology here, but concentrate more on the basic principles and practical solutions. This would be our roadmap for the next 30 to 40 minutes. First, let's begin with prematurity. Those who have handled at least one child weighing around, say, 750, 800 grams, we understand how difficult it is to handle them. So what is prematurity? It is defined and classified on the basis of gestational age. The cutoff is 37 to 38 weeks, 6 days, beyond which it's full term, before which we have the premature babies. It may be severe, moderate, or borderline. As per the body weights, the low birth weights are less than 2.5 kgs, and the other extreme is extremely low birth weight, less than or equal to 1 kg. The normal levels are between 2.5 to 4.2 kgs. One of the most significant problem among this population is apnea. So what is it? Apnea is defined as cessation of respiration for more than 20 seconds alone, or less than 20 seconds with accompanying bradycardia. That is a reduction of heart rate by 30 beats per minute of the basal level, along with cyanosis, pallor, or hypotonia. It is maximum up to 12 hours post-operatively and may continue up to 48 to 72 hours. Hence arises the question and safety of RSI and opioid usage in them. However, there is prophylactic treatment options with caffeine and aminophylline in these babies. Among other problems, we have bradycardia. Hence, we should prefer cardiostable drugs, use atropine pre-operatively, and avoid hypoxia, hypotension, acidosis as far as possible. They are also prone to hypothermia. Hence, the thermoneutral ambient temperature of 34 degrees should be maintained to prevent excessive heat loss. They are also present with sepsis, for which adequate antiseptic measures needs to be taken. There may be hyaline membrane disease, PDA, hence proper precautions are vital. Handling glucose is also very poor, especially in the first 2 days of life. Other than these, blindness and lung injury due to oxygen toxicity are major concerns. Next, we go to thermal regulation. We all know that neonates have a large surface to body weight ratio, reduced subcutaneous fat, underdeveloped ability to shiver in response to cold, greater body water content, but they have a specific feature of non-shivering thermogenesis, which I'll just discuss in my further slides. The normal temperatures, a full-term baby, somewhere around 36.3, 36.5 degrees Celsius. Environment temperature, 32 to 34 degrees Celsius, and preterm around 34. Hypothermia may be mild, moderate, severe. Severe is less than 32 degrees Celsius. Now, neonates lose heat mainly by these 4 processes: conduction, convection, radiation, evaporation. Now, a few words, what I was just talking about, non-shivering thermogenesis. Now, when a baby is exposed to cold stress, the glucose is utilized to produce heat. This activates the brown fat lipolysis, leading to conversion of the brown fat to glycerol and fatty acids. Now, if we allow it to go on and on and on for a prolonged period, the glucose store actually gets depleted. And the results are metabolic acidosis, peripheral vasoconstriction, and aerobic lipolysis increase. Hence, these are all detrimental to the body. So what are we supposed to do? So we can use certain things to prevent the cold stress in newborns in the OR, like using warming mattresses, warming, humidifying the inspiratory gases, save the volatile agents at 36 degrees centigrade, warming the IV fluids, warming the blood products, the skin preparation fluids, the irrigation fluids, the radiant, bare, hugger warmers can be used, or hot air drapes and garments. Now the transportation. All of us might think, just shifting the baby from a ward or then ICU to the NICU to the OT. What is it? Why is it so important? It is. A neonate should always be accompanied by expert medical and nursing personnel in incubators and isolates with heaters. If there is any ongoing IV fluids, drug infusions, it should continue. The monitoring should be uninterrupted and the transfer distance should be minimized as far as possible. Why? Because it has been reported that post-transport mortality is almost 15 to 36% in our country. That's quite high for a mortality rate. The fluids, the electrolytes, the glucose, the spinal cord of neonatal anesthesia, what I feel, despite it being a very hugely challenging thing, a well secured IV access is quintessential in neonatal anesthesia. Since most of the surgical patients are kept NPM for long durations at times due to the surgical comorbidities and all, early administration of IV fluids is vital to maintain normal hemodynamics. Mostly it's the intravenous route, it may be peripheral or central. In very critical babies, we might need an intra-arterial line, and the intraosseous route is for the emergency resuscitation. Most common cannulation sites for the peripheral IV access is scalp, dorsum of the hand, palmar surface of the wrist. The sizes of cannula 24G, 26G as per the weight and the gestational age of the baby. Site and then it should be well secured. We should avoid air bubbles, drugs to be diluted, slowly pushed, and all the rest of the precautions to be taken. Central IV access sites commonly are IJV, subclavian, femoral. Umbilical vein, it is accessible, but you need to avoid it because of the portal vein thrombosis. Disadvantages are there: malpositioning, infection, embolism, and thrombosis. So it is, if only it's necessary, essential, then go for it. In critically ill neonates, intra-arterial line. Right radial artery for the preductal and posterior tibial artery for the postductal. Sampling. Now, what are the uses? Monitoring the hemodynamic status and biochemical sampling. Now, we should be very careful regarding the heparin doses we use for flushing. Right? So, the dose is 0.1 to 1 unit per ml dissolved in half normal saline at the rate of 0.5 to 1 ml per hour. Remember to change the saline, heparinized saline, every 24 hours and do not administer fluid or any medication through them. Now, fluid and electrolytes should be used very judiciously. Too little, we may cause dehydration, hypotension, poor perfusion with acidosis, hypernatremia, cardiovascular collapse. Whereas too much of it causes pulmonary edema, congestive heart failure, opening of ductal shunt if any, bronchopulmonary dysplasias, intraventricular hemorrhage. So next we come to the most pertinent question. What is the type of fluid we use and when do we use it? So these are the recommendations by the APA guidelines. That is the first day, 10% dextrose. Day 2 to 7, 10% dextrose with or without electrolytes, sodium, potassium, provided that the urea, creatinine are within normal limits. Greater than day 7, isotonic fluids with supplementary electrolytes and minimum glucose. But in cases of preterms less than 1 kg, all babies not receiving feeds by day 3 start parenteral nutrition via the central line. Now the 3 pillars of fluid administration: replace the deficits, replace the ongoing losses, the third space loss, and maintain for the vital functions and growth. Continue the last 2 in the post-op period. Now, how do you assess? These are all same as other pediatric population. The important points are the core skin temperature is important, specific gravity of the urine and urine sodium levels are important here. And lastly, weight. Weigh each baby before planning for a blood administration, fluid administration, drug administration, anything. Now, first is the replacement of pre-existing deficits. Now, in the recent days, while we started following the ASA recommendations, the fasting periods have reduced. Earlier, like they used to be fasted from midnight and for 8 hours, 12 hours or more. Recently, we follow the guidelines, it's a very less period of fasting period. So in that case, we have the lesser episodes of dehydration, hypoglycemia, hypovolemia in a term healthy baby. Mind it, These are all for the term healthy baby. Whenever we are having a critically ill or sick preterm, they will be dehydrated even with a very short NPM period. Why? Additionally, because of the surgical illness, vomiting, diarrhea, early cord clamping, repeated blood sampling in the NICU and CRT. Now, how do you replace it? This replacement of the deficit should be done. You have to calculate it by the formula, that is the hourly requirement into hours of fluid restriction. Administer the 50% of the fluid calculated in the first hour, 25% in the next 2 hours, and along with the ongoing losses. The maintenance fluid in the neonates in the first 48 hours is 10% dextrose at the rate of 2 to 3 ml per kg per hour. That is around 40 to 80 ml per kg per day. Day 3 onwards, it's 0.18% normal saline in 10% dextrose at the rate of 4 ml per kg per hour. That is 100 to 120 ml per kg per day. So that was for the term healthy baby. Now this is the fluid requirement for the low birth weight infants in the first week of life. So it's very interesting to note that very low birth weight babies require comparatively greater amount of fluids than the term healthy babies in the initial days. See, it's 85, 105, and then when you are like having a 2 kg baby, it's 60, 75. Something about the maintenance fluid, it needs to be supplemented if the baby is having high fever, excessive sweating, hypermetabolic states such as burns, use of radiant heaters, phototherapy. Next, we come to the replacement of the ongoing losses. What are the ongoing losses? There may be fluid loss, there may be blood loss, and there may be third space loss. So fluid loss during surgery replaced with isotonic fluid such as 0.9% sodium chloride, ringalactate. Blood loss is replaced by crystalloid, colloid, or blood. The same formula as for bigger children, but here the estimated blood volume for preterm is 100 to 120 mils per kg, and for a term neonate, it's 90 mils per kg. This has to be taken into consideration. And in the setting of continued instability, ongoing blood loss, and cyanotic heart disease, blood replacement needs to be started a little bit earlier. Now the third space loss, what is it? Then the fluid which is sequestered from the vascular space into the tissue around the site of surgery has to be replaced by isotonic fluid. It's actually very difficult to quantify in neonates, but we can somehow like make a rough estimate. For superficial surgery, 1 to 2 mils per kg per hour. For thoracotomy, 4 to 7 mils per kg per hour. And abdominal surgery, 5 to 10 mils per kg per hour. It has been found that the loss will be less if the procedure is done by the laparoscopy technique. Next, we come to the post-operative fluid management. Isotonic maintenance of fluid with dextrose is to be continued, but restrict the volume. Do not give the whole of the required volume because the patient is under post-operative stress, lots of stress, which gives rise to high ADH level. When we are using hypotonic fluids in very small neonates, give half the average recommended maintenance fluid on the first day and do monitor sodium daily. If there is post-op fever, radiant warmers or blankets are being used, please supplement this fluid. Post-operatively, monitor the losses hourly, monitor serum electrolytes, and maintain an input-output chart. Now, when oral intake approximately hourly maintenance is equal to the hourly maintenance rate, it is then that we can discontinue IV fluids in them. Now, since the total fluid requirement is very small in these kids, we cannot use the normal drip chambers, the IV fluid administration devices which we use in adults. So we need to use these volumetric chambers. If it's unavailable, we can go for micro drip set. In rapid infusion of resuscitation of blood products and solutions, it is helpful if we use stopcock manifold in line, and we need to warm the fluids which we are administering. Now, a few words about the electrolytes. Now, these are the daily maintenance requirement of sodium, potassium, calcium. Sodium is around 2 to 4 millimoles per kg per day. But in preterms, where there is an immature renal like tubules and resulting there's increased urinary sodium loss, then this value may go up to 6 millimoles per kg per day. For potassium, it is 1 to 3 millimoles per kg per day. But in case of hyperkalemia, which might occur in 30 to 50% population with a birth weight of less than 1 kg, where there is a shift from the intracellular to the extracellular space, there we need to correct it. Why? Because otherwise the child will present with life-threatening arrhythmias. Another important dyselectrolytemia important in neonatal anesthesia is hypocalcemia. It is defined as levels of corrected total calcium less than 1.5 millimoles per liter. In symptomatic babies who will present with jitteriness, twitching, convulsions, prolonged QT, reduced cardiac contractility, and most importantly, delayed reversal. What do? We give 10% calcium gluconate, 6 mils for low birth weight, 10 mils for a full term. Asymptomatic, 10% calcium gluconate, 75 milligrams per kg per day. The target should be 8 to 10.5 milligrams per cent. Give it through central line, have a continuous ECG monitor, and give very slowly. It's a very cumbersome chart, but I've just put it here for your reference. This chart depicts the neonatal conditions like tracheoesophageal fistula, pyloric stenosis, peritonitis, GI obstruction, abdominal wall defects. What are the disturbances which might occur and what are the treatment? How do you replace it? The basics are all the same. You just need to know where is the loss from and you have to replenish it accordingly. Now, glucose homeostasis. It's very ill-developed, as I had always said before, and it's maximum in the first 2 days. And hypoglycemia, it's less than 30 milligram percent for a full term and is defined as less than 20 milligram percent in a day 1 and 2 low birth weight baby and less than 40 milligram percent in a low birth weight baby more than day 3 on the 3rd day. If the baby is symptomatic, that is symptomatic hypoglycemia, they present with apathy, apnea, high, weak pitched cries, cyanosis, hypotonia, hypothermia, tremors, and convulsions. We give a bolus of 50% dextrose at the rate of 1 to 2 mils per kg IV and a maintenance dose of 10 to 15% at the rate of 80 to 100 mils per kg per day. Asymptomatic, only maintenance of 10% glucose infusion at the rate 75 to 100 milligrams per kg per day, monitor every 4 to 6 hours. Target is, it has to be greater than 45 milligram percent. Now we have to understand that this glucose homeostasis, the hypoglycemia and hypoglycemia both are detrimental. So deleterious effect of hyperglycemia is hyperosmolality. Osmotic diuresis worsens the neurological outcome during cerebral ischemia. So, how long should we use dextrose? This is a very common question. So, the recommendations are use glucose-free isotonic crystalloids in all except babies less than 48 hours. In the first 2 days, it is mandatory to use 10% dextrose if and otherwise contraindicated. On perioperative babies who are on perioperative parenteral nutrition or on dextrose containing solutions prior to the surgery. If the baby is body weight is less than the 3rd percentile and it's undergoing a prolonged surgery or the baby has reduced sympathetic response to regional anesthesia, you should not use glucose in high doses. So next we come to the preoperative preparations. The OR preparation, mainly the temperature. We know what hypothermia can do to our child. So till now, the recommendations are ambient OR temperature should be 27 degrees or something between 25 to 28 degrees and skin temperature 36 degrees. Clinical skill, judgment and evaluation. These are the 3 time-tested, age-old pillars of monitoring, which we can never bypass. Color will tell us if the baby is pale or cyanotic. Chest mobility tells us whether the expansion is bilateral, the chest is compliant, the respiration pattern is good or not. The palpation will help us to know the temperature, the pulses, the peripheral perfusion. Among the another important indispensable monitor is the precordial stethoscope. It's safe, simple, effective method to assess the heart rate, the heart sounds, and rhythm. Esophageal stethoscope is another alternative which gives a non-invasive beat-to-beat variations. ECG to detect any arrhythmia, especially bradyarrhythmia. Pulse oximetry, if possible, use two, one for the preductal in the right hand, one for the postductal in the lower extremity. It should be appropriately fitting. That is very important because if we don't use the correct size, we'll have the wrong readings. Now, in the first 2 weeks, we should target an SpO2 of 95 to 97%. Why? Because too much will cause oxygen toxicity, too less is hypoxia. So, and the reading should always be correlated with PaO2 for valid interpretation of the data. Next comes non-invasive blood pressure. This oscillometric technique, proper neonatal cuff. A 4 centimeter cuff is recommended. The cycles must be at least 3 to 4 per 3 to 4 minutes to prevent limb ischemia. ETCO2 is another standard of care monitor which measures the adequacy of the respiration. It provides information related to rebreathing, ventilator disconnection, suspected air embolism, hypermetabolic rate, etc. Now, urine output. It's a simple measurement of hydration, circulatory volume, renal function. We all know that. A normal value range between 0.5 to 2 mils per kg per hour. We also know that. But if you have actually handled a very low birth weight baby, you would understand it's actually a huge challenge to even measure hourly or so. But still, we should try it out so that because it gives us a good thing about the renal function. Lastly, the thermal probes, the esophageal and rectal to assess the temperature. Now we come to the equipments. All equipments to be pre-tested for its workability, availability, and must be appropriate size. The breathing systems, which are light, with minimal resistance, reduce dead space, and allow for warming and humidification is always preferred. Now, there exist two schools of thought regarding which breathing system we should use. The old school prefers the valveless, the cheaper version, modified Jackson-Rees circuit. And it is said that it is easy to sense the minute changes in the compliance of the lung and the airway. But the modern school proposes the use of neonatal ventilators which are having pressure control cycles. Heat moisture exchangers are also very important. The other equipments are the laryngoscopes, Miller straight blade, we all know, 0001, mask of appropriate size, ET tubes of appropriate size, hydrochloride dressing, Duraplast. This is very important because the skin of the neonate is very soft and prolonged, keeping the other versions might injure the skin. A little bit about the depth of the endotracheal tube, because if the tube just goes in a bit more than it is required, what we call the bronchial intubation, it is actually a very bad thing for the neonate. Because post-operatively, you will land up with a white lung. So where do you actually fix it? A simple formula is here: 7 centimeter, 8 centimeter, 9 centimeter, 10 centimeter for a 1, 2, 3, 4 kg baby respectively. But auscultate, auscultate, auscultate. That is very important. The final decision you have to take clinically. No number is absolute here. Others are the suction catheters, correct size feeding tubes. Regarding supraglottic devices, all adult variants are available in size 1, including the iGel 2 to 5 kgs, AirQ disposable, which is available in 0.5 for body weights of less than 4 kgs, and LMA ProSeal is said to be better because it provides a better laryngeal seal and higher success rate. Now, the fasting guidelines, we all are aware of this: clear fluids 2 hours, breast milk 4 hours. Formula feed cow milk is rarely used in neonates, but if it is used, it's for 6 hours. Objective is to minimize gastric aspiration and prevent unnecessary long fasting intervals. This is very important for a low birth weight baby. Now, the preoperative preparation of history and examination, I won't go into much details. Some specific history questions are the gestational age, the birth weight, significant birth events or any ventilatory support requirement during birth. And we should always check the hydration status and the coexisting disease if it is present. That should be assessed by physical examination. The parents should be counseled by the planned conduct of anesthesia, about the pain relief, about blood transfusion, about invasive monitoring, and the requirement of post-operative HDO and ICU admission. All routine investigations to be done, but since most of the neonatal cases are emergencies, these values are mainly like for pre-op optimization of the baby rather than like taking up or not taking up deciding factor. So finally, what all things we should check before we take the baby on the table? First, fasting status. Next comes informed consent and patient identification. Try and avoid sedative premedicants as much as possible. Use anticholinergics, atropine 20 mics per kg IV. Please keep blood cross-matched if you feel it will be at all needed during the surgery, which is usually it is needed. Vitamin K 0.5 to 1 milligrams depending on the body weight. Stomach has to be decompressed by a feeding tube. Always estimate the blood volume and the fluid requirements before administrating it. And finally, if you think you'll be needing a central venous line or an arterial line, then please try and do it in the NICU before taking the baby into the OT. Now, the most important part, the intraoperative and the postoperative part. The induction, there's the ever-growing battle, inhalational or the IV. Among the inhalational agents, halothane is not much in use in neonates nowadays because it causes cardiovascular depression, hypotension, raised ICP. Even if when we are using it, we should use it in very low, like less than 2. Isoflurane is relatively contraindicated for induction, may be used for the maintenance in some cases. Desflurane, it's not used because it's very irritant, but it has been seen that in ex-premature infants who are more prone to apnea and respiratory depression, this desflurane is very helpful because it has the shortest recovery time. And about nitrous, it's contraindicated in cases like CDH, lobar emphysema, or NEC as it causes increase in the volume of the spaces, the compliant spaces. The MAC is generally lower in neonates. The onset of anesthesia is very fast due to rapid respiratory rate and high cardiac output. And regarding the IV induction, these two drugs, ketamine and thiopentone, but thiopentone is preferred, but in lower doses, 2 to 4 milligrams per kg. Ketamine not much of like in use, but may be used in critically unwell neonates with caution. And regarding the IV drugs, we should remember that the induction is very rapid and the recovery may be delayed, especially in preterms. So in that case, if the anesthesiologist is not confident that they can manage the airway, then they should give it a thought before giving it. And next, we come to the analgesics. Multimodal analgesia is preferred in all neonates. And since they show an exaggerated response to the narcotics, opioids has to be used, has to be very carefully titrated and respiration monitored. Paracetamol is very safe, 7.5 milligrams per kg IV or 20 milligrams per kg per rectal. Regional anesthesia is safe, and infiltration of the wound with local anesthetics in the form of caudal, in the form of intercostal blocks, lumbar epidural, it can be preferred wherever it is feasible. Avoid NSAIDs as much or almost avoid it. And there's no other view about it. And lastly, but not least, the non-nutritive sucking. It's actually very helpful in day-to-day practice where the baby cooperates, a difficult cannulation, or when it's very irritable, you can calm the child by just giving him a artificial nipple. Now regarding muscle relaxants, choline, too many side effects, think before using. Atracurium, 0.3 to 0.5 milligrams per kg. One good thing is that cis and atra both, the histamine release is almost negligible in children. Vecuronium, 0.05 to 0.1 milligrams per kg, but it may become longer acting in a neonate. So be careful when you are using vecuronium. Rocuronium is contraindicated as muscle relaxant. And the maintenance, we actually paralyze the baby because spontaneous thing is not preferred ever. So in gist, if we want to have a small gist of the whole thing, then we need to start with the oxygenation. The pre-oxygenation is very vital here. The oxygenation should be done preferably with air and oxygen. Try and avoid nitrous as much as possible. Next, give anticholinergics, give multimodal analgesics. Regarding choice of IV and inhalational induction, it's a personal choice depending on your preference, the relative hazards of regurgitation, the age and weight of the baby, the physical status of the child. You have to decide whether you want to use an IV or an inhalational route. Use short-acting muscle relaxants. You intubate, you bilaterally auscultate and confirm, fix the tube properly, maintain with pressure cycled IPPV if possible, or otherwise you can use the JR circuit as well. In IPPV, your fresh gas flow should be around 2 to 3 liters per minute. The peak airway pressure should be around 20 centimeters and the respiratory rate around 30 to 40 per minute. Now the warming, humidification, positioning and eye care. These are all very significant in the intraoperative period. We should always take care of these. The maintenance should be with Sevo, ISO, DES, as a whatever, and air oxygen 50-50 with a muscle relaxant. And hypoxia is harmful, so keep it within 91 to 95%. Reversal is same like all other pediatric population in neostigmine and atropine. 100% oxygen should be given till the baby returns to spontaneous respiration. Nostrils should be suctioned routinely and try and prefer to extubate awake if it is possible. But if there is a delay in reversal, explore the common causes like hypothermia, acidosis, hypocalcemia, and reduced or the residual relaxant effects. Now the post-operative. Now we will have two scenarios here. Either we have a baby who has returned to spontaneous respiration with adequate pain relief. Another group will be the ones who require ventilatory support. They need to be safely transported to the NICU. In the second case, we need to support the organ systems by minimal handling to prevent cross-infections, optimal positioning to give an optimum lung expansion, ventilatory supports, where do we need it? In abdominal defect surgery, where there is a reduced FRC, increased work of breathing, where high PEEP may reduce atelectasis. Judicious fluid, electrolytes and temperature monitoring in post-op. Try and maintain cardiac output as much as possible to the normal levels. Early recognition of hypovolemia, SIRS, DIC and its management. Post-op ileus is one common thing which is present. Try to decompress the stomach and replace the losses adequately. Finally, last but not the least, the behavioral issues. Yes, neonates. What do they feel? What do they understand? They do. Neonates are basically trust seekers. They have just come to the world and they are exploring it with their sensory and emerging motor abilities. So we need to give them positive sensory stimulations like soft touch. We need to provide a very safe environment for them. And only then will they be adjust to the very adverse hospital environment which they are suddenly placed in. Now we shall now quickly go through three specific cases. I know I'm running out of time. The first is the meningomyelocn. Just a few bullet points. The positioning is very important. Pre-intubation, care should be taken not to injure the lesion by using soft rings, pads and whatever. The head is stabilized adequately. In the post-intubation, the surgeons might need a lateral or a prone positioning. In these positions, care should be taken of the pressure points, the eye is properly padded. You should use armor tubes so that intraop head manipulation doesn't cause an unwanted extubation. The abdomen should be free from any pressure for proper ventilation. look for disconnection of the tube. And one important thing is when you're using long-acting muscle relaxants, you need to discuss it with the surgeons prior, so that like if they want to use intraop nerve stimulation, then you can like discuss it and then go further. In the post-op, you have to look for brainstem herniation features. If the baby is without a shunt, there may be features of hydrocephalus, and if it's worsening, then you should go for shunting. Next is tracheoesophageal fistula. First is classification of the type, and then is the vector. The cardiac lesions are very important here. One important thing is these babies are very prone to aspiration. So NPM, upright positioning, intermittent suctioning of the upper pouch, these are very important things to be taken care of. And monitors, try and use 2 pulse oximeters because they have cardiac lesions. Now, goals of inductions. It's very important here because you need to intubate the child while you need to minimize the distension of the stomach. The more the stomach is distended, the more like hemodynamically unstable your baby becomes. The conservative way, like the old dictum was awake intubation to avoid any positive pressure ventilation and all with proper analgesics, but it raised the intracranial pressure and there were intraventricular hemorrhages. So now the more acceptable ways are GA by inhalational route, but keep the spontaneous respiration. After intubation, fixation of the tube is another important thing. It should be distal to the fistula above the carina. Now, how do you assess whether you are in the right place? You can confirm by auscultation first. Second, you insert the tube either in the right or the left mainstem bronchus. Then gradually withdraw it until you find a bilateral ventilation establishment. Now, do not forget to auscultate the epigastric region ever, because that will give you a sign where you are. If there is a gastrostomy in situ, look for bubbling. If the bubbling is present, the tube is above. If there is no bubbling, it's below the fistula. If possible, direct visualization bronchoscopy is always preferred. The problems intraoperatively, maintenance of adequate oxygenation. Because you are sharing the airway with the surgeons, the blood, the secretions in the ET tube, there will be airway obstruction and frequent tracheal suctioning is required, which also in turn will lead to hypoxemia. The surgical airway manipulations and collapse of the upper lung by use of retractors mark hypoxemia. So you should be in close communication with the surgeons. Like whenever you're feeling that you're going beyond the safe limit, you ask them to stop, you blow the lungs, and then again come back. Preparedness for accidental extubation and emergency reintubation is must. Post-op period, one major thing is fix the nasopharyngeal suction catheter, because if it proceeds inside, it might injure the anastomotic site, causing again a reopening and other catastrophes. Pain, post-op pain should be handled properly with multimodal analgesics, as we have spoken earlier. And the last case is congenital diaphragmatic hernia. It's very difficult to summarize in just 1 or 2 slides, but I'm just giving an effort. We might discuss it in the further classes. First, we need to preoperatively optimize the child. The persistent pulmonary hypertension needs to be controlled as far as possible. Intraoperatively, go for awake intubation, avoid bag mask ventilation, positive pressure ventilation till you have intubated the child, avoid nitrous, have a good pain control, maintain with low flow till chest is decompressed, and prevent hypothermia. These are the mechanical ventilatory goals. We go for permissive hypercapnia, ductal to SpO2 will be preductal will be greater than 85%, aim for a pH of greater than 7.2, keep the peak inspiratory pressure less than 25 centimeter of water and have adequate P. Postoperatively treat the acidosis, pulmonary hypertension, use ECMO if required, and always try and go for awake extubation. So what are the take-home messages? Prima non nocere, as for all other patients. First, do no harm. Be as physiologic as possible. Proper optimization, preparation of the baby and the theater. Warm, safe, adequately man-powered environment. A safe transit. a well secured intravascular access, look, feel, touch. Empathy and compassion is a very important part of this subject. And finally, prepare well, be vigilant, and act fast. There's no conflicts of interest. For further reading, thank you.
Thank you, Anisha, for a wonderful, wonderful presentation. And in a gist, I think it's a lovely way of putting the basics of neonatal anesthesia with a little peek on the case scenarios that we had thought will be very, very helpful for the exam going students. I think those are the three ones that kind of encompasses what neonatal anesthesia is. We'll quickly go through some of the questions. Dr. Amitava Layak, who is in the Indian Armed Forces, a very dear friend of mine now, asks you whether there is any specific consideration or special considerations for in neonatal anesthesia during the COVID pandemic.
That's seriously a very good question and very pertinent question. Now, regarding this neonatal anesthesia in the COVID era, the main thing is that here we have to compromise, we have to have a midline between safety of ourselves and the safety of the baby. So the considerations are the OT preparations and all are similar with those of other pediatrics and other things. Regarding deep or awake extubation, there is still a lot of debate going on, because if you go for a deep extubation, you are protected, the baby is not, sometimes not. And if you go for an awake extubation, you might not be protected, the baby might be. So we are still working on it, which is the best way to handle the neonates, specifically neonates.
Yeah, absolutely. I think it's an evolving time.
Exactly. We're learning with each case.
Maybe.
Yeah, we are actually learning with each case and with each baby.
Right. Okay. Dr. Krishnendu Chaudhary, a very senior anesthesiologist in this city, wants to ask you, is there any schedule for blood glucose testing? How often do you do it? And in special circumstances, what is the changes that you do?
Right. So blood glucose monitoring, in neonates, the recommendations are we should do it every 4 hourly. Until and unless if you are having a hypoglycemic baby, it should be hourly, 1 or 2 hourly, but then again you have to go back to the 4 hourly regimen. This is the APA guidelines which they have there. It's our pediatric guidelines. Unfortunately, very less data, very less guidelines are available in the neonatal anesthesia as such. So we have to take help of the pediatrics and the medicine people to
Okay. Fine. I think that answers Dr. Chaudhary's question. Dr. Krishnendu Chandra, he wants to know in which cases or specific cases would you think of going to invasive arterial lines, invasive blood pressure monitoring in neonatal?
Yeah, as I've already mentioned, it's a critically ill with septicemia, DIC, in cases where you need to, in cardiac cases where the baby has to be monitored, beat to beat monitoring variations are required, we will go for intraarterial.
There were few queries about the role of propofol and rocuronium in infants and pediatrics, infants and neonates. I kind of said that, well, you have to use it. If you ask a yes or no question, I don't think you can say yes or no.
Yeah, exactly.
My take is you can use it, but use it with caution. No,
exactly.
To affect the pharmacodynamics and pharmacokinetics. Exactly. Okay. I think there is a question about pre-oxygenation and rapid sequence induction in neonates. What is your take on that?
Yeah, pre-oxygenation, it is always we have to do it with oxygen air. We cannot usually do it with 100% oxygen. That is one indication. If it is possible, And regarding the what was the other one? Hello.
Rapid sequence induction.
Yeah, rapid sequence induction is the apnea. If it's a premature preterm baby, then there is a query whether you should actually go for the rapid sequence, how much it can tolerate, and regarding the use of choline, because there is still yet to be another agent which is like equivalent to choline without the side effects. So rapid sequence is also a take. The same thing, like if you have to use it, then you have to be like caution and prematurate it properly, avoid the bradycardia and rest of the thing.
Yeah, this is an interesting question, Anisha, for you. What would you prefer in tracheoesophageal fistula? Would it be rapid sequence induction or a conventional intubation? Induction.
No, what I do, the second conventional, that is, I do it under GA with inhalational with spontaneous respiration, because that is safe for what I have been doing. So I guess.
I think that's a very well taken thing. This is a lot of people would go by that. This is from Dr. Debashish Roy. He thanks you for that excellent talk. And regarding perioperative apnea, though the literature says that there is no difference in apnea incidence between general anesthesia and regional anesthesia, what is your personal?
Yes, it's a very good thing he asked this, because I missed it out in the PPT, because the regional anesthesia is also like a culprit. If we have apnea, we fear GA, the same thing, same incidence will or might occur even when you are giving regional anesthesia. So it's actually more, the risk is more in GA, but it is not absent in regional. You have to put it that way. So whenever you are giving a regional, you have to give a general anesthesia along with it. You cannot go along with just a regional because of other factors also, which have already been explained. So we need to go with GA and regional, but there are no documents as such as I've not found as such like that regional is perfectly safe, that it does not cause any apnea also.
Right. How will you deal with post-extubation laryngospasm? And this comes from a very, very senior person, Dr. Tanmoy Dash. And one of these guys, a legend in pediatric cardiac anesthesia at one point of time in this city and possibly in the country.
Yeah, post-extubation laryngospasm, a very dreadful thing in neonate. But yes, we have to get prepared. Like, we don't cause it. All the preparations to avoid it. But if we cannot avoid it, first thing we need to do is go for the. Hello?
Yeah, you can hear you.
Yeah, so we should go for the ideal teaching which we have been taught, that we should go for Succinylcholine, because they don't give us time, and in the COVID era this is what is the thing. But when we are in the pre-COVID era, we can go for thiopenton and we can release it, intubate, deepen the plane. That's it.
Okay. Thank you very much, Anisha, and we will not keep you held up anymore. So, first and foremost, about the developing brain and anesthesia, there is this person who also has the developing brain, and with that, I declare my conflict of interest, which is obvious, though we like the good things in life, and despite the COVID era or not, but I don't have any conflict of interest on this particular presentation. See, the conflict with anesthesia, neonates, infants, the developing brain, the first conflict is that it is very well known that the use of a balanced anesthetic technique is beneficial in decreasing the neuroendocrine and the metabolic stress response to surgery and altering the pain processing. where it was Anand who discussed about not only the neonate, but also during fetal surgery that you have to take care of pain. You had Fitzgerald who thought about this cutaneous hypersensitivity following peripheral tissue damage, and he was talking about including vaccination and how it altered their sense later on. And then we had people like Taddeo who said that, if there was neonatal circumcision and if it was done without taking care of the pain, it had a significant effect later on in life and when they saw a painful procedure like vaccination. So it is essential that you take care of pain in neonates. And if you look at it from the physiological point of view, the nociceptive nervous system is mostly mature by 23 to 25 weeks post-conceptual age in humans. The nociceptive nervous system is, but the anti-nociceptive system develops much later in infancy, which means that premature and term infants are more sensitive to pain than adults. And why is this pain, especially if you don't take care of it, when they're having pain, bad for the developing brain? Is because a chronic painful stimuli can provoke cell death in many areas of the brain, whether it is in the cortex, the thalamus, hypothalamus, amygdala, hippocampus. So it can cause cell death. So it's not a good thing to have. And of course, if you decide to withhold anesthesia during a painful procedure, it leads to poorer surgical outcomes, and long-term effects are seen later in childhood. And there were allusions to this in the first slide that I showed about neurodevelopmental issues, behavioral issues, and cognitive defects. So the conflict is that you should be taking care of pain. You should be taking care of consciousness when an infant or a neonate undergoes a surgical or a painful procedure. The second part of it is, this is when you throw a cat amongst the pigeons, is there has been this data which has been amassing in the literature regarding the potential adverse effects of anesthesia exposure on the developing human brain. Oppenheim, and this again is, these are elegant ones, not necessarily on human beings, but saying that it can cause cell death during development of the nervous system. The blockade of NMDA receptors can lead to apoptotic neurodegeneration in the developing brain. But what actually made people look into this kind of studies was very, very elegant studies which came out from Columbia. I think it's Columbia, Dr. Vesna, and don't ask me to pronounce the next part of her name, whether early exposure to common anesthetic agents cause widespread neurodegeneration in the developing rat brain. Is there another microphone which is on? Jayati, can you please take care of that? So
yes, sir, done.
Yeah, which brings us to the Act 3, Scene 1, the Hamletian question, or you can say the Heiderian question, to give or not to give, which is, will you give anesthetics to a surgical procedure? Will you withhold anesthetics during a surgical procedure? And will you give something which has got this potential or the neurotoxicity that comes inherently packaged with this drug? So that is this dilemma, to give or not to give. Let us look into the developing brain to understand this, okay? So immediately after birth, the brain is about 25% the adult size and is unevenly matured. The brainstem and the spinal cord are relatively well developed, whereas the limbic system and the cerebral cortex are still immature. Despite being produced before birth, the cortical neurons are poorly connected, and most of the synapses are produced after birth during what is called the exuberant phase, where there is this synaptogenesis that is happening. Okay, so this is happening after a little later on. So the newborn brain now also contains little myelin, and myelination appears to be virtually an automatic or an innate process. And for this automatic or innate process, you need sensory afferent stimuli to these neurons and the neuronal pathways, and which essentially is the neuroplasticity of the central nervous system. But this neuroplasticity of the central nervous system is a two-edged sword. And I think this is the fundamental area from where this conflict starts. You need this neuroplasticity. You need young children's brains, which should be open to learning and enriching influence so that this automatic or innate process develops. But at the same time, it leaves them vulnerable and susceptible to a bad environmental input. So when you come to the neuronal communication of the brain, you have on one side the excitatory glutamate receptors and the inhibitory GABA receptors. And this is there in the neonate infants, and it is there as it is in the adult anatomy as well. What has been seen is that in the developing central nervous system, GABA receptors can also be excitatory, and this has possibly something to do about how anesthetics can influence the neurodevelopment of the central nervous system, which people are thinking about. You need the neurotransmitters. You need in the developing brain, these neurotransmitters play a central role in brain morphogenesis, in the formation of synapses, the proliferation, the migration of neural networks, the differentiation of the neurons, and the survival of the neurons. So you need these neurotransmitters. And during the very early stages of normal brain development, that is neurogenesis, neurons are produced much in excess. That we do not, the child or the developing child will not need this excessive neurons. And around 50 to 70% of all the neurons or the progenitor cells that are produced are eliminated. So they are lost. And this is critical for normal brain structure and function. In later stages of normal brain development, that is during synaptogenesis, and this is obviously later on, neuronal elimination is very tightly controlled. A small number of neurons are destined to die. These excess cells are eliminated by an inherent program or an inherent cell death program, which is called apoptosis. And this apoptosis is mediated by a caspase enzyme system within the cytosol, which can again be intrinsic and extrinsic. And this is a cartoon about how the programmed cell death or apoptosis happens. You have a normal cell which shrinks because of chromatin condensation. There is membrane blebbing, then the nucleus collapses, and there is continued, and then it becomes the small body formations, which is called the apoptotic body formations, and there is subsequently the lysis of the apoptotic bodies. This is programmed cell death. This is because you have excess and you want to get rid of the excess. Now let us bring in the topic of interest, that is the anesthetic agents, are they neurotoxic? Now, general anesthetics, we all know, are highly lipid soluble. They can dissolve in every membrane, they can penetrate into organelles and interact with numerous cellular constituents. This is typically because of their lipid solubility. They have the possibility and the potential to affect gene expression and therefore protein synthesis and processing and therefore cellular function. How? It is still poorly understood. Plausible biochemical substrates for durable long-term effects in a number of tissues have been thought about. We still do not know how it happens. How did the effect? Now, this is coming to the core issue about how is it thought of that this anesthetic agents can be neurotoxic. Now, one of the things that people have thought about is this neurotoxicity is by increased apoptosis, or you are causing programmed cell death in the central nervous system. The other mechanism is it's not just apoptosis, or it could be apoptosis, plus it could be receptor mediated blocking of NMDA receptors or stimulation of the GABA receptor. So it is also could be receptor mediated. Now, apoptosis, how it is? Now, we thought that apoptosis could be intrinsic, extrinsic. This happens to the intrinsic pathway, and which is the mitochondrial dependent pathway. The anesthetic drugs causes an increase in the mitochondrial membrane permeability, and therefore can release cytochrome C into the cytosol, and therefore there is a recruitment of the caspase system, and moment the caspase system is recruited, it leads to, as we thought, it is mediated by caspase, so it leads to apoptosis. And this is a cartoon again how it happens. So it can go in through receptors, or in go in through just the lipid permeability, goes into the mitochondria, releases cytochrome C, the caspase system is activated, and it leads to the programmed, as you can see on the top bottom left corner, the commitment to cell death. So that is about how it can. Now, okay, let us accept that it is bad. When is it bad? So what is this susceptible period? The preclinical, and this is what we talk about about preclinical, is essentially non-human studies. So preclinical studies strongly suggest a narrow window of susceptibility to this anesthesia-induced neurodegeneration. In the developing animal brain, is particularly vulnerable to neuronal cell death after anesthetic exposure in rodents up to 7 days of age, and in rhesus monkeys before 5 days of age. And the vulnerability quickly diminishes with increasing age. What about human vulnerability? Estimates for the equivalent time period in humans have ranged from the 3rd trimester of gestation to 3 years of age. So therefore, neonates, infants, and toddlers are vulnerable to anesthesia-induced neurotoxicity. This is a cartoon from the Translation of Time, which essentially this came about the development of the brain, and when you're trying to translate things that have happened with rodents and rhesus monkeys and what can happen to human beings, and why the 7 days and 5 days in this particular in primates and in rodents translates to up to 3 years. And if you're interested, this is a lovely website called Translating Time, and especially the translating time between various animals and the development of the brain. And that is how they have arrived at this 3 years time. So what are these studies on rodents and monkeys, and what do they tell us? People have found, and this from Dr. Vesna being one of the proponents on this, when anesthetic and sedative agents are administered to rodents during the synaptogenesis phase, which is again the 7-day thing, or rapid brain growth, they cause widespread neuronal apoptosis, neurodegeneration, and changes in neuron growth and cell structure. And this is what they have found, maybe looking at the brain. And from that, they have also found that the rodents who have been given anesthetics have had subsequent learning and behavioral abnormalities later on when they attained adulthood. In neonatal monkeys, ketamine or isoflurane given during this vulnerable period of brain growth causes widespread neuronal death and neural degeneration. Ketamine given to neonatal monkeys resulted in long-term behavioral abnormalities and impairments in learning and memory when the monkeys became adults. what now is the human story. It's, I think, the early 90s to and in the last couple of decades, you will find quite a few publications, and this is from the one that is a meta-analysis of that. Not a huge number, but quite a few. Not big studies, most of them small, some of them reasonably big, and most of them retrospective. And they have tried to see, and they have cohorted with it with siblings, with other normals, and try to figure out what is happening to behavioral changes, memory, cognitive functions, and learning ability on given anesthetics. And the available data so far points to a possible association between anesthetic exposure in early childhood and some learning disability. Some, and I think a collection of this, have suggested that a dose-response effect may be present. What essentially is meant by a dose-response effect is that if a particular child has received anesthetic for a longer duration or more than one, then he or she is more likely to develop a problem than the ones who have got it for a short period of time or possibly only once. But then again, you need to be always cautious with conclusions drawn for retrospective studies. But the only challenge here is that to get to a very good conclusion, planning a prospective study and for a long period of time is a huge challenge. See, the association between early anesthesia exposure and subsequent learning disability does not indicate. This is the people who are who are on the con side would say that why are you saying that somebody who received their anesthesia exposure and then has learning disability, is it only due to anesthesia neurotoxicity? There could be many known and unknown confounding factors. There could be some known coexisting medical or surgical disease which leads to learning disability, which is part and parcel. Many of these studies have not accounted for that. The surgical pathology for which the person needed anesthesia, is that responsible for changes in the development of the brain? The surgical pathophysiology for which the person needed a procedure, does that lead to a lower nutritional status in that particular infant and neonate? Does that contribute to neuronal development? That is another confounding factor that we need to understand. The other thing is, people who have received even more than one anesthetics have obviously had more hospitalization. They've stayed in hospitals for a longer period of time. They have had breaks in their normal learning process. Does that also contribute to this cognitive functions which have to develop later on in childhood, the learning ability and everything? So is anesthesia, is your Sevoflurane, is your propofol, is your isoflurane, or is your ketamine responsible, or is this other things, are these other things also responsible, which makes it a very difficult thing to point that no, it is only anesthesia that is responsible, nothing else. Neurocognitive outcome is difficult to study in children because of growing complexity in the neurocognitive development as they age. So if you're trying to break it at 5 years, 7 years, 8 years, 10 years, 12 years, you'll find that you need to possibly check huge number of domains. So you need to, therefore, this is not this people on the con side says that the psychometric tests need to assess domains which were not applicable at younger age, and more domains need to be tested. If you're really interested, then please, I can give you Dr. Anjan Bhattacharya's number, who's a master in development pediatrics. You can talk with him and figure out how these are done. So it is not known which domain is affected most by anesthesia and its neurotoxic effect. So why is this difference between rodents, primates, and neonates? Thankfully, they are not the same, and they do not look the same, and their brains also do not behave the same way. The points to ponder is the prolonged duration of exposure to anesthetic agents. And even like one of the severe criticism of the preclinical studies has been that they have used kind of the dosaging pattern of whether it is ketamine or the inhalation pattern of isoflurane, which is similar to what has been used in humans. So without knowing what is actually the MAC values for isoflurane in rodents and monkeys, or what is the effect of the ketamine, and what is the anesthetic doses that you need for a ketamine. The second thing that has been hugely criticized in the preclinical studies has been that you have given an anesthetic wherein there has been no surgical stimulus, there has been no painful stimulus, and so you have been they have been bombarded with chemicals onto the brain without a necessity for shutting off parts of the brain. Even when you talk about the human studies, and this is what I already talked about, how much would you did you take in factor in the nutritional and the metabolic needs of the humans receiving general anesthetic? What was the monitoring standards that were used during the support? And remember, this is happening in the 70s, 80s and getting published, and people then thinking about it. So is it due to the drug, or is it due to an hypoxic episode that happened, or is it due to something else, a hypotensive episode that happened, perfusion related, that is causing problems with the perfusion to the central nervous system and its added effects? And how, as again, dosing was severely questioned, and the divergent effects of anesthetic drugs given in, as I talked about, the surgical pain or stress. So the clinical relevance, as we stand today, should we be concerned? I think yes, we should be concerned, because there is some data available that yes, it can cause development, or as I can put it, some alterations in the development of the central nervous system. Is it a cause for continued research efforts? Definitely. And should we therefore, based upon this, just change our sound clinical practice about giving anesthesia to people who are an infant or a neonate who's coming for a surgical procedure? I think no, stay tuned. So what is the evidence so far? And this is, I could find, I think, these three huge, I think today, publications. This gas study, I think it's good. I think I saw Kajori had logged in from Australia. So this Murdoch's is, I think Murdoch's Children's Research is one of the big thing in Melbourne, and they started this gas study early to 2010-11, if I remember correctly, and it got published last year in the Lancet. And they looked at 28 hospitals in Australia, New Zealand, Italy, USA, UK, Canada, and infants of less than 60 weeks post-menstrual age who were born at more than 26 weeks gestation were undergoing an inguinal herniorrhaphy without previous exposure to general anesthesia or without any risks of a neurological injury. So the patients were randomly assigned 1:1 to receive either awake regional anesthetic or a sevoflurane based general anesthetic for their hernia surgery. The primary outcome measure that was being done was a full-scale intelligence quotient, FSIQ, or the Wechsler Preschool and Primary School of Intelligence Third Edition, the WPPSI-3, at 5 years of age. So between February 9, 2007 to January 31st, 2013, so 6 years period, 4,023 infants were screened and 722 are finally randomly allocated. 363 awake regional anesthesia, 359 general anesthesia. The median duration of general anesthesia was 54 minutes with an interquartile range of 41 to 70. And what did they find? The FSIQ score was 99.08 in the awake regional group and 98.97 in the GA group. The difference in means was only 0.23. This provided a strong evidence of equivalence. So this results of the intention to treat analysis were similar to those of the per protocol analysis. So interpretation is slightly less than 1 hour of general anesthesia in early infancy does not alter neurodevelopmental outcomes at the age of 5 compared with awake regional anesthesia in a predominantly male study population. And the ANSCA came out with their strong recommendation that general anesthesia is therefore safe for young children. There is no significant difference in IQ scores. There is no differences in neurobehavioral and cognitive function. With the only caveat that since 84% of the study participants were male, more research was needed to confirm the findings in girls, and we also needed to find out what will happen when you have anesthesia with prolonged exposure. So that was about the gas study. Now let us talk about this PANDA study. Now PANDA is nothing but pediatric anesthesia and neurodevelopmental assessment. So this is still an ongoing study, but now it has become a kind of a group, the PANDA group. This started in 14th April. If you go to clinicaltrials.gov, you'll find it. 2009 until 2018, I think they're still recruiting, but they have met at several times in the interim, and people with similar kind of interests have come out with their findings. And one of the biggest one that has come out so far has been whether anesthesia is safe in the young, which was from the Columbia University by one of the principal inside being Sun. Sun has been one of those people who has been hugely involved with the neurotoxicity of the developing brain in children. And they looked into association between a single general anesthesia exposure before the age 36 months and neurocognitive outcomes in later childhood. This was published in JAMA in 2016. So this is among the PANDA group. The objective was to examine if a single anesthesia exposure in otherwise healthy young children was associated with impaired neurocognitive development and abnormal behavior in later childhood. So this was a sibling matched cohort study done between May 2009 and April 2015 in 4 university US-based pediatric tertiary care hospitals. So sibling pairs within 36 months in age, currently between 8 to 15 years old, and these exposed siblings were healthy at surgery and during anesthesia, and their neurocognitive and behavioral outcomes were prospectively assessed, and the retrospectively documented anesthesia exposure data were collected. A single exposure to general anesthesia during inguinal hernia surgery in the exposed sibling was 1 arm, and no anesthesia exposure in the unexposed sibling prior to 36 months of age was the other arm. Primary outcomes was global cognitive function. Secondary outcomes included domain-specific neurocognitive functions and behavior, a detailed neuropsychological battery-assessed IQ and domain-specific neurocognitive functions, and parents completed a validated standardized reports of behavior. What was the result? Among the 105 sibling pairs, the exposed siblings, the mean age of 17.3 months at surgery, or which needed anesthetics, 9.5% female, and the unexposed siblings had 44% were females, had IQ testing done at the mean ages between 10.6 and 10.9 years respectively. All exposed children received inhaled anesthetic agents, and anesthesia duration ranged from 20 to 240 minutes with a median duration of 80 minutes. Results: the exposed siblings IQ scores: full scale 111, performance 108, verbal 111, unexposed full scale 111, performance 107, verbal 111. So there was hardly any differences in the IQ scores between the siblings pairs. Nothing that is anywhere statistically significant. So the result is there is no statistically significant difference in mean scores between the sibling pairs vis-a-vis memory, learning, motor processing speed, visuospatial function, attention, executive functions, language, or behavior. So the conclusion and relevance of this was, among healthy children with a single anesthesia exposure before the age of 36 months, compared with healthy siblings with no anesthesia exposure, there was no statistically significant difference in IQ scores in later childhood. But they have said that we need to see what happens with repeated exposure, maybe prolonged exposure, and in the vulnerable subgroups. Finally, what about the mask study? This is from Mayo Clinic, and this got published 2018 July in Anesthesiology. Unexposed, now there is singly exposed, and now they have brought in another arm, which is multiply exposed children who were born in Olmsted County, Minnesota from 1994 to 2007, were sampled using a propensity guided approach, which means that you are doing treatment and you're trying to find out data and you're kind of looking at data which with the treatment intention for treatment was what it is supposed to be. And they underwent neuropsychological testing at ages between 8 to 12 or between 15 to 20 years, a little later on. The primary outcome they are looking at is again full-scale intelligence quotient and the WSPPI-3. The secondary outcomes included individual domains from a comprehensive neuropsychological assessment and parent reports. And what did they find? So unexposed 411, single exposure 380, multiple exposures 206 children. And if you're looking at intelligence quotient of the exposed children versus the unexposed, in the with single exposure, the intelligence quotient was 0.5 points lower, not statistically significant. Even with multiple exposures, the IQ fell down by 1.3, again not statistically significant. So that was about primary outcome and IQs. Secondary outcomes: processing speed and fine motor abilities were decreased in children with multiple exposures. There were no significant differences in attention, memory, executive function, expressive language, visual motor abilities, or visual spatial abilities between the exposed and either unexposed and either the single or multiple exposed category. And parental reports: parents of children with multiple exposures reported more problems related to executive function, behavior, and reading, but not mathematics. Parents of children with single exposure reported more problems with executive function and reading. So this is secondary outcome results. So the conclusion from the mask study was anesthesia exposure before the age of 3 years was not associated with deficits in primary outcome of general intelligence, which is hardcore objective data. The secondary outcomes, which they say needs to be interpreted cautiously, suggest the hypothesis that multiple but not single exposures are associated with a pattern of changes in specific neuropsychological domains. We thought about learning, behavior, not necessarily maths, that is associated with behavioral and learning difficulties. So from this, whatever we heard, what is the take-home message? And the take-home message is not necessarily what I'm trying to tell you. This is a take-home message from another. I think Michael Pinsky set this up, which is the Smart Starts International Anesthesia Research Society initiative. They came out with a consensus statement in 2015. I was hoping that they've come out with something more recently. But this is what they have to say on the use of anesthetic and sedative drugs in infants and toddlers. And this is what they have to say. 6 bullet points. Brain function is very complex and cannot be fully measured with a single cognitive test. How does exposure to anesthetics affect the development of other important functions such as memory, language, motor skills, and emotional development is still not known. Sevoflurane is only one of the drugs used in general anesthesia. Do other commonly drugs produce similar results? Needed to be found out. Many procedures require a combination of 2 or more anesthetics. Do the effects change when drugs are combined? Need to be known. Different medical procedures may combine with anesthetics to produce other outcomes. Are the results same for the other procedures than hernia repair? Because if you look at all this, whether the gas, the JAMA 2016 are dealing with hernia surgeries. Much brain development occurs throughout childhood. What are the exposure of anesthetics in subsequent months or children or years? We need to find out. The animal and epidemiological data suggests that the risk of anesthetics to the developing brain increases with long duration of exposure, multiple exposures, which is kind of mimicked by the mask study, the secondary outcome. Is this actually true? We need to find out. So this has been their thing. So what can be done in the future? And this is, I think, taking it a little too far, but I thought just for the heck of it, put it up, that we need to have approaches and techniques for detecting potential neuronal toxicity associated with anesthesia exposure. And how can this be done is to create a bridge between the information that we have between preclinical and this clinical anesthesia projects. The way of doing it possibly is in vivo imaging of the rodent and non-human primates by micropositive PET studies for an objective and quantitative assessment of the functional and molecular targets in a longitudinal manner, and then find out what is the cognitive and behavioral studies, put this together, and then find out what are the structure and functional issues that were not, which will possibly not be visible by other imaging studies, and which is related to anesthesia. And then if you look at molecular tracers, which can label the apoptotic neurons in the brain affected anesthesia exposed rodents, ability to how they visualize and quantify the neurotoxicity. And then if you know these tracers, and then you can do live PET imaging while a human child is getting an anesthetic. Are those areas also getting affected? And can you apply the tracers and then maybe take these particular anatomical locations at which it has been found out, employ those radioactive tracers, and then possibly looking at, I think, stem cell biology or neuro, and how, don't ask me what it is, and then find out whether these tissues, if they are given these anesthetics, maybe in vitro, and then find, is there any changes that are happening to the neurons over there. So this is possibly the future. So summary, prolonged and persistent exposure to anesthetic leads to accelerated neurodegeneration. This is kind of accepted. Fetuses and neonates subject to pain and stress are also equally at risk for long-term adverse outcomes. So alleviation of pain and stress during the perinatal period is essential and humane. So the clinicians should continue to administer anesthesia to newborn infants and pregnant mothers. As such, there is yet no need to pre-warn patients or take a special consent for the neurotoxicity of anesthetics. Only two things that you can possibly do till 3 years of age is avoid unnecessary prolonged period of exposure. And if there is a surgery, which the outcomes do not change whether you do it prior to 3 years of age or after 3 years of age, it possibly makes sense to delay it and do it after the age of 3. Thank you very much for a patient listening.
I'd like to thank you on behalf of HCP Forum for starting this academic endeavor with us. We hope to have you in many more future sessions, of course, and I would request all of you who have joined us tonight to please give us a feedback about whatever you find good, whatever you find needs improvement in this forum. So thank you, everyone. Thank you for joining. Thank you, Dr. Sengupta. We will close here tonight. Have a good night.
Thank you. Bye.